Hey guys, my hair is long enough that I can throw it back now. Wednesday's lesson of the day, today on Thursday, is about this area right here. And the two things I want to talk about is the Prejowl Sulcus. So if you guys hate your jowls, you should hate the sulcus in front of it just as much. And the other thing is witch's chin, which a lot of people don't know what it is. And we'll go over these two things. So witch's chin, because we had a couple people coming in today talking about this. Witch's chin is due to several things, but it's when you smile from the side, the chin just kind of hangs off the edge instead of being attached to the bone really, really strongly there. The reason this happens on many people from treatments is because they overfill the area. So they put either fat in the chin, which fat doesn't really belong in the chin to graft so much. You can put like a tiny bit, it's fine, or too much filler. That's the majority of patients. Some patients get it after they get maxillofacial surgery or genioplasty, where the chin internally can get detached and they don't reattach it to the gums properly. And the other reason it happens, which is what we saw recently and posted about today, if you want to see, is because of poor muscle support and drooping. So what you notice is the muscles over here can actually indent like a dimple, and then you have a slope that goes down to the neck that exaggerates it. So for this patient that we posted earlier, you can see exactly what's happening there. When she smiles, her chin drops down really tight, her neck contracts this way because her hyoid is down over here, and ends up getting this really deep indentation right in the middle that rides up the side of the face. And to fix this, it's pretty easy. If you fix it in your clinic, you can do it with filler. You can put filler, it's not into the crease. You put filler under the muscle to pop the muscle connection out. When the muscle is like this, the two muscles, and they flex like that, and you get witch's chin. If you push them out, meaning you put filler deep to this area to pop out the muscles, now they contract like normal, just like that. And that's what we did for her. In addition, you can improve the contracture by relieving the stress on it by lifting the hyoid to a higher position. Should we call it the hyoid? Should be in a high position. And that's the bone down over here, which all this stuff attaches to, and you put it right back up there. It should be at the level of your chin horizontally. That's the best solution for witch's chin. The reason most surgeons can't fix it is they don't know the reason that it occurs. So you have to identify the reason and be able to treat it. In order to treat it, you have to place the incision at a different place. And unfortunately, most people put the incision into the area which is indenting, which just makes it worse because you end up getting hollowing in that region. As you cut into it, you cut off the blood supply. As you cauterize, you melt fat, and you disinsert the muscle slightly over there sometimes. And the whole issue in the first place is poor muscle function. So it is better to put the incision anterior to it if possible, and then you can treat everything as you go back into the neck. You fat graft at the beginning of the case, that pops it out. You have to fat graft all the way up here, all the way down here, which is a weird place for people to fat graft. In the clinic, you just put filler deep to it, and it pops it out, and you're fine. And then you can go superficially once you ride up the face, if you see those lines that people form up on the side of the face. So that is the main solution for witch's chin. If you have laxity from loss of chin support, meaning you did a volume reduction on the chin, then it's really difficult to fix. If you have overfilling or doughiness, you have to follow up with doing radiofrequency treatments and skin tightening, and that's really what helps it in those cases. So chin suspension works in some patients, chin tightening with radiofrequency works in some patients, and then supporting the indentation of musculature works for some patients. The Prejowl Sulcus is a place that is very, very poorly understood. And the reason it is poorly understood is because most people aren't familiar with what happens to it with age. They kind of assume that the jowls droop down, and that's what creates what the Prejowl Sulcus looks like, which is an indentation here in front of your jowls. However, if you know the anatomy well over here and you've seen it open a bunch of times, you realize that in older patients, the fat in that area is almost gone. And the layers of fat you have there are the hypodermal fat, which is the little tiny fat cells just under your reticular dermis, and they fit into the grooves in your reticular dermis. And then you have below that the SMAS fat, which that area of the SMAS doesn't have much fat at all. It is the tiniest layer that is above your depressor anguli oris muscle as it wraps around to your platysma. What happens with age is this area deflates and it gets darker. It gets darker not because a shadow is being thrown on it from the jowl. It gets darker because you're missing yellow under the skin, and the light reflects straight through your dermis to the muscle back to your eye. So what you're seeing is the muscle. You're seeing darkness in the muscle, which is what's reflecting. So you need to put a spacer in there. The other thing that is in this area is what we call mandibular ligament. It is something that's referred to in facelifting surgery, and it is said that it needs to be released to get proper rotation of this area. And realistically, if you look at the large majority of people, that is not true. It doesn't need to be released. You can do something better, which is just fat grafting it. If you fat graft into this area, the collapse, which you notice as tethering, goes away. So most people think that the tethering is there on its own, or that it kind of happened over time, or that the ligament formed over time, and this isn't true. The osteocutaneous connections have always been there since childhood. The reason they look tethered is not because they got tethered. It's not because of anything else or contraction that's occurred with age. It's because of deflation. So to fix deflation, you don't cut deflation, you inflate deflation. And that's the best solution because you get better coloration there on the large majority of patients. Now, some patients do still need mandibular ligament release. However, most of them you get away with fat grafting. So why is that important? Number one, you get better color correction. Number two, you get better contour correction if you look at 100 patients in a row. You can always find 10, 20 patients which don't really need it, and you do the release and you're like, oh my God, look, I did a great job, but you really just did a good facelift. The other reason is because when you cut into this area, it causes bleeding. Bleeding is annoying. It can cause hematoma, and it also causes you to go cauterize it, which can cause more ischemia. And already when you elevate this area, you get ischemia to the area of the incision, so you can get more ischemic changes there. So if you can avoid mandibular ligament release, you avoid it. If you need to do it, you do it. I do it all the time. I do it when needed, but I do as little as possible. And the way I do as little as possible is by fat injecting before the case starts. And then when I go and I pull up on the face, I realize it's not necessary in the large majority of patients. So if you look at my results, most of them don't have much mandibular ligament release, and they still get a killer result with less bruising and less ischemia around the incision. So that's the reason it forms, and that's why I like to treat it that way as opposed to just doing mandibular ligament release, which doesn't fix it on everybody, whereas fat grafting really does. Now, a lift is really the most important part, so people do great lifts, correct it mostly anyways. However, these little darkening indentations and those kind of things you will find on some patients that weren't fixed with just pure release of the mandibular ligament. If you're trying to do a non-invasive improvement of this area, the best way to do that is with radiofrequency skin tightening. You can tighten the whole face and neck with Profound. That diminishes the amount of the jowl prominence, and then you can do a little bit of filler there. Now, the filler here should be placed superficial under the skin. One for safety. If you go down onto the bone, you go a little bit higher. There is the mental foramen, which you have a neurovascular bundle coming out of it. It has recurrent vasculature that goes down into the neck here, so you can get ischemia of this region with vascular occlusion. The other is, again, for the color correction. You're placing a spacer gel underneath the skin so it ends up reflecting more brightly and you don't see as much of a shadow. It's also more high yield. When you inject on the bone, it doesn't really improve it that much. When you inject it under the skin, it really reinflates that area that was collapsed more appropriately. So that's the best place to place it if you're doing a filler. So you do radiofrequency first, and then you follow up by doing a filler. So let's see if we have any questions here. It's a quick lesson of the day. ¿Cómo estás? Bien, gracias. Hey, best doctor I know in plastics. Hello. Hola, doctor. Josh. Hi, Josh. Hate jowls. Agreed. How do you get rid of jowls? Facelift, mainly lifting. The answer how not to get rid of jowls is don't do liposuction on them. That is a very common thing that's done in surgery, and you have to remember that the most commonly performed things in plastic surgery are usually, or the most commonly performed types of techniques are usually the worst. That's why not everybody is great, because they're performing inadequate things. So liposuction of the jowls is one of those things. Doesn't mean you can't get an improvement in the jowls. It means the reason I say don't do it is because it can cause issues and indentations, and later if you lift the face, it doesn't look great. You have an indentation, and realistically, it's not fat that you need to remove anyways, so better not to. Facial exercise. Does facial exercise help with jowls? It can in some people. I don't know which ones or how. Some people it can help just because they change their facial dynamic. Just like if you're somebody who's always doing this, if you're practicing more of an upward smile for a long time, you can actually retrain yourself, so you do behavioral modification for that. Hello from Texas. Hello from California. She looked like she was in a lot of pain. She was not in any pain. She was a week out from surgery, had pain probably the first night with some headache from the brow lift, and then didn't have any pain otherwise. I am the one from Chihuahua Airport. Oh, it's good to see you again. Thank you for coming to the airport and saying bye to us when we were leaving last time. I hope they invite me back soon. I hate the lines around my mouth. They're not bad. Where's your location? Beverly Hills. How about short, wide neck? Is there a fix for this? In some patients, yes. We use a technique called the mastoid crevasse, where if it's wide from the front and contiguous, you can actually indent it. It looks better. Skin tightening for a 50-year-old, profound is the best one by far. Do dentures provide better lip support than implant arches? Depends on the face. Better question for a dentist, but it depends on the face. Can you release the mandibular ligament with cannula, inject HA fillers? So you don't release the ligament. It doesn't need to be released. It needs to be reinflated. So yes, you can, and you just get a cannula and you inject right under the skin, and you can go like a millimeter deeper than that too, and it reinflates very quickly. It's best to use a cannula because of the propensity for bruising. Sam, the best wrestler in the world, joined. He's in Ibiza, son of a bitch. Great. Is deep plane necessary? Is logic necessary? It's not necessary, but logic is good, and you should do things that are logical. Anything but a deep plane is illogical because it's not the glide plane of the face. Which filler is best? They're all good. I mean, just the ones that are more prone to migrate are the more hydrophilic ones, like the classic Juvederm, and all the other ones. They don't migrate as much, but you can still use it without it migrating. Just don't put much, and you'll be fine. All right, where did I learn to speak Spanish? In Spanish school, 6th grade. Face yoga. I'm unfamiliar with it, Dr. Vergara. I don't know. I'm not sure, actually, but I'm curious about it. How about SoftWave? SoftWave is a very cool device, transcutaneous without any needles, so it is nice, and it actually has good deposition of energy with a proper fluence, which is your energy placement per square centimeter, so that's fantastic. I like SoftWave. Do I prefer fat injection to other fillers? No, it just depends where. Fillers are always easier, and you can actually do more with fillers than you can with fat, but fat is also fantastic. All right, so I think that's it. Hope everyone has a fantastic Thursday and a great weekend. You will hopefully find me on the ocean. Oh yeah, bobbleheads, Jen, Rob,